Hello, and thank you for joining us today for this CME activity, Various Perspectives in Atopic Dermatitis, Scratching Beneath the Surface. I'm Dr. Paul DeGramji, family physician at Collegeville Family Practice in Collegeville, Pennsylvania, and medical director of health services at Ursinus College, also in Collegeville, Pennsylvania. The purpose of this program is to discuss the diagnosis and management of atopic dermatitis in the primary care setting, focusing on the role of shared decision-making in improving patient outcomes. This program has been developed in association with the National Eczema Association and the Coalition United for Better Eczema Care, or CUBE-C. Dr. Eichenfield, would you please introduce yourself?
Sure, I'm Dr. Larry Eichenfield. I'm professor of dermatology and pediatrics and chief of pediatric dermatology at the University of California, San Diego, and Rady Children's Hospital, San Diego.
Thank you, Larry. And Jonathan?
Hi, I'm Jonathan Spergel. I am professor of pediatrics and chief of the Allergy section at the Children's Hospital of Philadelphia and at the Prevalence School of Medicine at the University of Pennsylvania.
Excellent, thank you. Welcome, gentlemen. Today we also have Janine. Janine, will you introduce yourself and tell us a little bit about yourself?
Sure. My name's Janine, and I am a patient with atopic dermatitis, and I have had it since birth, basically.
As we go through this, we expect you to tell us all about your situation, and it'll be very interesting to our audience. Now let's first talk about the National Eczema Association and the CUBE-C initiative and how it supports patient-centered approach. Larry?
So the National Eczema Association is this incredible group that's a patient advocacy group that has that supports individuals and families with atopic dermatitis, but also influences the field of eczema. Mm-hmm. And through their support of education, excellence in patient care and research, really trying to move the field forward. And it was decided that there is a lot of information on eczema that healthcare practitioners across the spectrum of care, primary care to specialist care, could probably do better in terms of their knowledge base, and that it would probably be a good thing to try to get a curriculum together that would enforce the new information on eczema and to sort of have a standardized knowledge base. So the CUBE-C initiative from the National Eczema Association is Coalition United for Better Eczema Care. And it's this recognition that we could come up with essentially a curriculum across the spectrum of care. And we got together experts, allergists, dermatologists, mental health care practitioners, primary care practitioners, to put together a core set of materials for healthcare professionals, whether they be primary care or specialists. We've putting it together, I think it's been really exciting. We published a set of articles as core materials. There are these PowerPoint modules that exist, but the idea is that we know that we can do better to deliver better information. There's a lot of new information about atopic dermatitis, about the underpinnings of it, the pathogenesis of it, and lots of new therapies. The initiative stresses what's called shared patient decision-making and involving our patients in deciding how it is that we're going to treat going forward. Mm-hmm. And so that's what the CUBE-C's created.
Fantastic. The website informative for patients as well as clinicians?
Yes, yeah. Well, the National Eczema Association has tremendous amounts of information that's really helpful to patients and families.
Well, speaking of information, let's get right down initially to the prevalence of atopic dermatitis and how it really presents in the clinic. Maybe you can also refer to it in a primary care clinic or practice as well as a dermatology. So let's take a prevalence first.
The prevalence of atopic dermatitis in children in the United States is around 20%. It actually varies by state to state. That number is pretty typical around the world for pediatric atopic dermatitis in industrialized countries. So clearly it's a high prevalence in early life, and often atopic dermatitis can start in early life. Now, when it comes to adult prevalence data, there's a variety of figures, but around 10.2% of American adults have atopic dermatitis, and some of that is persistent dermatitis that started in childhood and hasn't gone away. In other cases, it's atopic dermatitis that started in later life. life, so-called adult onset atopic dermatitis. Overall, we see that atopic dermatitis has high prevalence with more than 30 million people in the United States affected.
So we see it at any age group, but predominantly it's a pediatric situation, right?
Yes.
And from the statistics you told me, it seems like people outgrow it, right?
Sort of. So the
I would
answer
beg to
is,
differ.
I mean, obviously Janine hasn't outgrown it, and that's not uncommon. I mean, eczema typically presents in that first 6 months of life, and as you there's a percent that completely outgrow it. There's a percent, so it's like, you always say a third in medicine. It's another a third. Yeah. There's about a third who really outgrow it. A third sort of stays the same, and a third sort of actually gets a little bit worse as you get older. This also, as you go on in the primary care, these patients are also, we think about outgrowing things, also at risk for like developing other things as we go on. Like these patients with atopic dermatitis are very, not all, but are at increased risk to develop asthma and allergic rhinitis. So it's part of this whole spectrum that we see. And you see it in our primary care visits. Is that baby who's scratching all the time, waking up, making them miserable, making the parents miserable, and they have that red, itchy rash that you see throughout the body.
We certainly do.
In fact, I think this is one of the big takeaways that I want for primary care practice is to understand that the old story of atopic dermatitis being a disease that presents in the first 2 years and then goes away is an oversimplification. And there's much more sophisticated data that reflects what Jonathan said, which is that you have different types of courses of the disease, and we shouldn't think that you don't need to manage disease, it'll just burn out and go away on its own.
Well, let's talk about that. I mean, Janine is here. Janine, you started at a pretty young age with atopic dermatitis. Can you tell us your experience and your recollection of how things started?
Sure. I was really young, obviously, and I had to work with my mother a lot, I was very lucky, she's a nurse. But so I would go to the doctor often because I had pretty bad AD, eczema, and we try all sorts of different things because when you're young, you try to stay away from steroids as much as possible. So we did tar wraps, all sorts of different things. Like I wore socks to sleep and
over your hands.
Over my hands, to prevent scratching. I not only went to like a primary care physician, I eventually went to an allergist and a dermatologist and tried testing. And so it's a lot of like going back and forth of seeing what will work, what won't work.
How old were you when it presented, Janine?
My mother says I was probably 2 months old.
Wow.
So
what do you recall as far as your symptoms? I mean, specifically.
My symptoms, so not being able to sleep, having really very, very, very itchy. And so, scratching my skin silly, especially in the inner arms at that time, just like completely red and difficult to move. So.
Were you given both topical medications as well as oral medications?
When I was young, I don't think I was giving anything oral, aside from the comorbidities of I often would have to take antibiotics for ear infections and things like that because I just think it's all related somehow.
Yes. But gentlemen, let me also ask you this question. So in primary care, how do we make this differential diagnosis? I mean, Janine had all this itchiness and she went to primary care. What can you tell us about making the differential diagnosis that this is what it is and this is the direction we should go?
Well, simply, first of all, labeling. We use the term eczema as a broad label. And most people, when they think of eczema, are using the term for atopic dermatitis. But we want to be specific that atopic dermatitis is an eczematous rashes that present in the typical pattern. And it's really typical morphology, presentation, chronicity, where it starts early on the face and the extensors in young kids, very commonly gets into the folds, and their patterns are a little bit different in adults, but it's both the eczematous rashes with that particular findings over time. And that's probably the most important thing. It should be a pruritic condition. There's a chronicity to it. It can be associated with having elevated IgE levels, but it doesn't have to. And then there are these secondary characteristics. So predominantly it's still a clinical diagnosis. You don't need to send blood work off to make a diagnosis of atopic dermatitis. But in the differential changes according to sort of the age of the patient and how they present. So when you were a little baby at 4 months of age, you might have been trying to separate out from seborrheic dermatitis and cradle cap. We wanted to make sure that it wasn't scabies or just some other infection or impetigo. We wanted to consider more significant diseases that can present with eczematous dermatitis but have something more than eczema behind them. An adult presents with new onset atopic dermatitis, then you're worried about either infectious mimics or especially cutaneous lymphoma, which can look very eczematous, but obviously has a different prognosis, so you have to be more careful depending upon the presentation at different ages.
So as far as the presentation, let me just say this, Jonathan, I'll ask you this question. So are we talking about a very itchy pruritic rash, is that correct?
Yeah, so I mean,
That's the first thing?
That's the first thing. So I was going to say, it's this itchy rash. You have this, it's very, very itchy, and as Larry just said, it's one of those typical spots that you see.
Let's talk about the typical spots, and where are they?
So in the little kids, it's typically your cheeks. Your cheeks and sort of extensive surfaces. As they get older, it really moves to sort of your creases. So you can almost think about it in sort of, you need, in the science that sort of supports this, you need just motion. So the kids rub their face against things, and that rubbing and that breaking down actually damages the skin barrier, and that causes that eczema cycle to start. So your arms move. So you get it in your hands, your elbows, your knees, and little kids just rub things that they can rub where they typically get it.
So also bilaterally symmetrical, is also?
Yes, definitely.
And also the appearance of the rash, obviously it's red, dry, and flaky as well?
Yeah, but that's not, yes, the answer is, but also you had pointed out symmetricality, but that's one of the also important points for a differential diagnosis. If you have someone who comes in with a local, regional eczema and is only regional in a funky location, then you have to consider allergic contact dermatitis. So for instance, if someone has an eczema rash around the belly button, you worry about whether they're nickel allergic and it's the snaps of their genes that's causing an allergy. Now, people with atopic dermatitis can also have contact allergy as well.
Yes.
Yeah. So, but that's something that's in the differential diagnosis. So if you're allergic to fragrances, for instance, that can be its own diagnosis, or it can be an exacerbator of atopic
Right, you can almost see where things are. Like if you see someone who's eczema, or the rash ends where the shirt is, or it's just on the face, then you worry, and they work in like a industry, it's just being exposed to whatever they're hitting their face. So a lot of this looks on presentation where things are.
Yeah, so in other words, it's really simple to make the diagnosis of eczema unless it's tricky.
Very good point.
And the other key thing is, when things don't behave like you should always take that differential that Larry was talking about, that hey, we're treating with this and it's not getting better, or it's in an unusual step. Then is that when you have to go back to that differential and say, hey, something doesn't fit, let me reevaluate. That's always a really important thing. If it's in your normal spots and you get better with your normal medications, you're probably okay. But when it doesn't fit, and when things are sort of not behaving when you think, that's when you have to take a step back and make sure that, hey, am I not missing? Am I treating the wrong thing?
Larry, you said about a temporal aspect. What did you mean by that, like time frame?
Well, one of the things about eczema that can be very frustrating, if you have it, is that there's an inconsistent course to it. So there's some individuals where you can treat them with a good topical intervention, topical steroids, nonsteroids, and they'll get better, pretty quickly, 1 to 2 weeks of therapy, and then all they'll need is really important, good maintenance skin care, and they may go a few weeks or months without having symptoms or flares of the disease. And that's a very different course over time than someone whose eczema may always be there. When's the last time is your skin good now?
No, actually, just 2 days ago. I mean, I am on a drug that helps me out a lot, but I still flare and have hot spots, and just like 2 days ago.
Did you ever have a time period where you just had like continuous degrees of eczema, never cleared up for months at a time?
Yes, for a few years at a time.
So in other words, so the course of the disease makes a big difference, and when you're assessing disease severity, part of the severity is looking at the qualities of the skin, parts the extent of the skin, but unless you're asking about the course of it, you're missing an important factor.
Very good.
Because certainly in terms of how you figure out what your intervention should be, the therapy should be, what you really want to do is minimize the influence of the disease on the life of the patient, and so you need to get a sense of what the course is.
Is it seasonal?
So it depends on the patient. So a lot of people's eczema will flare in dry weather. So one of the big things with eczema is keeping the skin well conditioned and keeping it moist. So in the winter in the Northeast or maybe even northern parts of the United States, it's going to be dry, right? And that's going to make your eczema worse. And some eczema is going to flare when it's hot and sweaty because sweat irritates your skin. Yeah. So their eczema is going to flare in the summer when it's hot.
Okay.
And then there's some people, there's not a lot, who actually eczema is going to flare from pollen. So the answer is maybe.
Okay.
Yeah.
So I see what you're saying. You got to be on the lookout for variations.
Right.
Is it important, or how do you actually differentiate between, let's say, mild, moderate, and severe? Is it important to differentiate, and how do you do that?
You're looking at what you are now, so you have an acute episode, so you have acute flares, and then what you are sort of like a baseline. And when you get baseline, what do you need to get to be that almost clear or totally clear? Am I just using good skincare that I'm bathing correctly and putting on moisturizer? Well, that's not too bad. But if I need to use lots of medications, either topical medications or systemic medications that are really strong agents, even though I've gotten them clear and now the flares are infrequent, I'm using big guns to control them, and that makes them more severe. So it's a mixture of what you look like now, how often you get bad, and what medications you need to stay well.
So let's talk about then the management of atopic dermatitis in primary care. Gentlemen, first of all, let's talk about mild disease. What do we do? I mean, that's the most common thing.
Right.
Either children or adolescents or even adults coming in with mild disease. Where do we go from there?
So the first line is always good skincare. So it's going over what are you doing for your skin. It's sort of the basic questions. How often do you shower? What soap do you use? What are you putting on your skin? Are you using any moisturizers? It's those really basic questions. Because, as you said, most patients are mild.
Yeah.
If you do basic skincare, you're going to control most patients. I mean,
So what's basic skincare? Can you please tell us that?
So this is always a little debate, but most of us believe is moisturizing.
With what?
So a good moisturizer. There's lots of ones out there. You want things that are rich in the oils that most people miss in the skin. So you want to moisturize once or twice a day. There's lots of brands that exist. You probably a lot of the ones that have lots of these botanicals can cause problems in many people, so I tend to avoid things that have botanicals and all those things. Some really basic ones. You want a non-drying soap. And then in terms of showering, bathing, there's always two schools. There's the dry school and the wet school. So as an allergist, I always believe in the wet school because you want to remove any allergens, irritants off the skin as soon as you get out of that
So what
bath.
he means by that is that there have been variations. People for years would say, oh, eczema skin's dry skin is more open. If you bathe, you'll end up drying out the skin more, so avoid bathing. And that's pretty much been put to rest, that doesn't work. If you moisturize after bathing, or you just moisturize, your skin will become moister. If you bathe and don't moisturize afterwards,
bad.
then that can dry out your skin. But the science has been done behind that. Now the frequency of bathing, there's not good data to argue
One way or the other.
More than, but most experts will recommend daily bathing or every other day bathing, but frequent moisturization.
So you moisturize twice a day. We recommend at least, not more.
These are mundane questions, but I need to know. Is bath better than shower, or does it make a difference?
Probably doesn't make a difference.
Okay, so either bath or shower.
Yeah.
So you take your bath or your shower, and by the way, any specific type of soap that we should or should not use?
Basically a non-sensitized, non-drying soap. I don't want to.
Non-sensitizing and non-dry. Scent make a difference?
It can in some people.
Okay.
Yeah, if you're allergic, then it can. So
Yes.
we generally will
Recommend
stay
it
away.
not
For
scented.
example, I can't use anything that has any fragrance at all.
And you get out of the shower, then you want to use a moisturizer.
So the core intervention of good skincare hasn't changed in 30 years, but actually the knowledge base of what's going wrong has. There is this inherent dysfunction in the skin that with proteins that are missing in some individuals, so the skin's truly drier, and because it's more open, it evaporates more. So the water evaporates, which makes it drier, and it's more open,
You get
so
more-
it can get more
more-
sensitized and
get more
easier to-
infections, get more allergens. So you
So-
need
so
you need
yeah.
you need to basically make a skin barrier.
Okay.
And depending on how dry you are, that may influence the gooiness of the moisturizer that's suggested
so,
for you.
so you can go anything from like Vaseline, which is really goosey, then you can use things that are rich in the extra fats and lipids that you miss, which is the science that Larry was just talking about that we have more, which is like the CeraVe, right? Or then some of the new Avenos and Eucerins have these extra fats in them. Or so we
and they work their way down to very light lotions that you put them on and they evaporate very quickly.
Yeah.
And if you had really dry skin, it'll have a 10-minute effect.
I see.
But if you don't have that dry skin, it may be perfectly adequate.
Yeah. So parents need to kind of experiment to see what their children do well with. But do I understand this correctly, that it's one of those things you got to do regularly every day, even when you don't have a bad flare or something?
Yes, that's
Yes.
part of the core maintenance treatment.
Because everyone with eczema skin, even things that are not red and itchy, are abnormal. We know those areas are dry, that they have this leakiness that Larry was just talking about, so we always need to moisturize.
Okay. Excellent.
We're finishing the discussion of the mild, but one of the things we didn't say, which we should stay clear, is that mild disease, sometimes the moisturizers will be enough to manage it. And if you can control the itch and you don't have active rashes, then that's great. Then your maintenance therapy is your core intervention. But when you get a flare beyond what a moisturizer can handle, then you have active inflammation, which presents as rashes in the skin as well as itch. Then you need anti-inflammatory agents. Okay. And generally we use our topical anti-inflammatory agents, which include our topical steroids, which range in strength from incredibly weak to incredibly strong. And unfortunately, there's no set numbering scheme, so people can get really confused about how strong their topical steroids are. And you should be very concerned potentially about very strong topical steroids, but very mild topical steroids have a ton of safety with them. Yeah. And then there's a series of anti-inflammatory non-steroids, and they include the calcineurin inhibitors, pimecrolimus and tacrolimus, and then there's a new non-steroid called crisaborole, which is a topical PDE4 inhibitor. The non-steroids don't thin the skin. They don't have cortisol in them. The topical corticosteroids are somewhat natural to a degree. If we make our own cortisol, and sometimes we use topical corticosteroids. But there's this range in terms of strength and efficacy and side effects.
Yeah.
That's a trade-off, and that's why we want we want to come up with a specific regimen to how to manage the flare, usually topically. As the skin-directed therapy is what we say to try to cool it down.
Yeah, so I agree completely with what Larry said, but it's important to realize that the mild topical steroids are the stuff ranges from the over-the-counter stuff that you buy at your local drugstore. Those are really safe and probably can be used almost every day without really side effects. The really potent stuff you really can't use for more than a couple days without worrying about skin thinning. So it is that range, but the really mild stuff, they're probably okay and not really worrying about it. So you do have to the range, and the new non-steroidal ones exist, and those are more for either people we need maintenance all the time for those, or they're having side effects from the steroids.
So this is one of the issues that we face with eczema is how can you, in a primary care setting especially, how can you educate the patients that they can control the disease? You help them to control the disease. And just the discussion of topical steroids, you sort of have to come up with either written material or some basic discussion so they understand that the difference between 1% hydrocortisone, 0.1% triamcinolone, and 0.05% clobetasol just happens to be that 1% hydrocortisone is over the counter and you could probably eat it. 0.1% triamcinolone represents our mid-strength, and 0.05% clobetasol just happens to be 2,200 times stronger than 1% hydrocortisone.
And it's
the
really
numbers
difficult.
don't correlate.
Yeah, I used to write face on my topical steroids, or body, so that I know that's not the right one.
We often will label things with green dots, yellow dots, red dots. So you'll do labeling. So the green ones, that's when things are not bad.
Yeah.
Yellow when you're getting a little bit bad, and red when you're really bad. So you sort of need to label things because it gets, as Janine says, it can get really confusing.
And you don't want to be putting the strong stuff on your face, so it's not good.
Well, that gets to very important things. In primary care, we're creatures of habit. We like to find something that works and stick with it, right?
Yes.
So you've given us some ideas about when to use mild ones, moderate, and strong ones, and you've given us some medications. Parents, however, they'll come in and they'll say, I'm worried that this is a steroid. How much of it gets absorbed, and how much of it can I use on my child?
So there's two different ways we'd handle that. If I'm talking to a group of specialists, I'll go through the data and I say, here's 14 clinical studies on these topical corticosteroids showing safety. I'm not going to go through that with parents, but what I'll say is, look, there's this really broad evidence of safety depending on the strength. So we want you to know sort of what the strength is. And the other thing is that we should tell you how much medicine to use, because we'll know how much is relatively safe. So if I give you a bottle of this certain type of topical steroid oil, if that bottle's lasting a month in your 9-month-old child, that's okay. Now, if you need a bottle every week, that's too much. I need to hear about it. We need to do a different regimen. So sometimes prescribing a quantity of medicine that's a safe amount is really helpful for the individual or the family, because then they know this is a safe amount.
So untreated disease is bad, not only it's bad for the patient, they're itchy, sleeping and not waking up at night, they're just miserable, right? But it's also going to lead to lots of problems down the line. It's going to make them more allergic and create all these other problems. So you need to use the medicine, and as Larry says, use enough medicine to make them well, but don't go overboard. So that thing is how fast you go through the tube, and what size tube did you get from the pharmacy?
Yeah.
Because some pharmacists give you the little sample size tubes, like, you have eczema over 50% of your body. You need a tub, okay? Take the tub, use this tub to get your eczema clear, and come back in 2 weeks, let me see, and then we'll say, okay, this is what you need, this is the minimum amount, this is sort of the max, and let me know what's going on.
Okay. Well, Janine, I want to ask you what your experience has been with medication. After that, gentleman, I want to ask you when I should refer to you. So, Janine, first of all, tell us what happened with you as far as which medications, because you told us about having these different faces and what to put on medications. Tell us about that.
Right. So it's super complicated because having had eczema my whole life, and kind of recurring, we were talking about the timeline, it was very cyclical, so it would come every few months, or sometimes it would be tough for a long time or a short time, and depending on the part of the body, you would want topical steroids for your face or for your body, and truthfully, and I'm being completely honest here, I would forget. Because you get clear for a while, and then you're like, oh, I'm flaring again. Let's bring out the drawer of topical steroids.
So are you saying when you're doing well that you forget to use your medicines?
I wouldn't use topical.
That happens all the time.
Of course, that is a very common thing. It's like,
Everyone
why
does
would
that.
you do it? Because you're not thinking about it. Because you don't think about it. But yes, so I would have the topical steroids when I try only to use them when I absolutely needed them, but then they build up over time, and you're just like, which one is this? I don't know, and
Did your parents help you with that? I'm sorry.
I think when I was younger they did, and then I had it for so long that they just kind of let me take over, I think.
So in your teen life, maybe you were making more of the decisions on your own,
is that
right?
definitely. In my teen life, I was making the decisions.
So one of the things we've been stressing over the last few years, because of listening to our patients, is to take more of the asthma model and bring it to eczema, where we do what's called proactive rather than just reactive response. Traditionally, as what we've talked about so far, was the sense of using moisturizers. You have a flare, you do your intervention, then you try to go back to nothing in between. But for a lot of patients, that's a failed strategy, because you need more controller meds in between your flares. So we have a lot of patients who might be on twice a week topical steroids, or one of the non-steroids, a calcineurin inhibitor or a PDE4 inhibitor, and we say twice a week, even if you're doing well. If you know you have your hot spots, Monday, Thursday, put the medicine on your hot spots. So the concept of a continuous regimen of controlling the disease, not waiting for flares to happen. And I think that's something that sort of is a messaging we're continuing to push out, so that we don't, so there's, if you're doing it regularly and you're doing it twice a week, and that's part of the regimen, is like controller therapy for asthma, that may be a more successful way of minimizing the disease influence.
Well,
and I think that all the creams and whatnot, I always moisturize. Like even if I wasn't flaring, that was something that keeping everything and triggers as far away as possible. So, always moisturize, shower after you're out in allergens, all of that's part of it.
So, we get some excellent ideas here, but in primary care, we all have our points where we say, I don't want to do this anymore without help. So when do you think it's appropriate for a primary care provider to refer to you gentlemen for some help?
There's some really obvious one. When you think it's not fitting the right pattern, like, look, it's not on the right spot, it's asymmetric, they're getting some weird infections, they're getting too many infections. When something doesn't fit the pattern, probably time to send them. And I also think it's time, like, hey, I'm giving topical steroids and they're not really working, or I'm trying this topical medication and they're going through it really fast and I can't really control it, then it's also, again, it's probably a hint of time when we need to send them to a specialist.
Yeah. So you're talking about diagnosis, confirmation, but as well management difficulties and getting advice on what would be the best pattern.
And management difficulties, as Jonathan pointed out, buried in that was two things. Number one is that you're having problems getting them under control, or having problems keeping the patient under control, and or there's still so much persistent disease, even if they're okay control, there's just too much burden of the disease. We have this revolution of therapy. We're getting new topical therapies, and now we have systemic agents that are going to be used a lot more. Historically, in atopic dermatitis, people didn't treat with systemic agents. We didn't have any approved in the United States other than corticosteroids, prednisone, which isn't advised by any group to use because it can really have such negative effects. And there's so many flares. If you give someone a course of prednisone, they flare afterwards, sometimes terribly. In controlled studies, they had to stop the studies early in the corticosteroid arm because they were having so much problems with it. So, but there's new therapies coming. We have an approved biologic agent that is blocks a very small subset of inflammatory cytokines, and it can be a breakthrough. So there's more of a burden on primary care to recognize those patients who are still miserable with their disease. And if they're too active, or they're still miserable, then I think it's totally appropriate for them to get referred on.
I refer a patient to one of you. When do you guys actually do testing? You said earlier there's no specific test, but there's patch testing, allergy testing.
Sure. So is when we see that patient, we say, like, hey, we can't control it. So, and so the people always ask, especially as an allergist, people ask me, like, oh, I'm sure I'm allergic to bananas and peas is causing my eczema. I'm like, really, probably not. Not doing what they were told to do.
Okay.
We'll leave it at that. And so when those patients, when we see them and like, hey, when we try to get them better and we can't, when we really say, look, hey, you need something all the time, then we think about, hey, is it for patch testing, is it a contact dermatitis? And then often we'll send them to someone who does that. Or it's like, hey, it's not getting better, and it's especially more so in the little kids. Because in the little kids, occasionally you'll get a food trigger. Uncommon, but it does happen. And then it's usually only a few foods. It's usually, statistically, it's most likely to be egg, but it's like 4 or 5 foods. Sending these blood tests for 50 foods, it's great for the company that does the blood tests.
Not good for patients?
Bad.
So you don't do blood tests on children? For allergy, food testing, is that right?
So, different
He's a food allergy expert.
So it depends on the answer. So for diagnosing blood tests for someone who comes to my office and has eczema, am I going to do blood tests to figure out what food causes it?
Yes.
No.
Okay.
Absolutely not.
If 30 to 40% of moderate severe eczema kids will have at least one real food allergy.
Now I got confused.
It may not, okay, so they really can have food allergy. It just may not be triggering their eczema.
Right.
Oh,
So
Maybe that identifying that
Right.
food and getting it out of the diet does nothing for the eczema,
Right.
but they're definitely in a different group in terms of their chance of having a real food allergy.
Right. So what Larry just says, like a lot of these kids will eat peanuts, right, and get hives and classic peanut allergy, but that peanut is not causing their eczema. They just have concurrent food allergies.
Okay.
That's
a very important point.
So the concurrent food allergies, we'll do skin tests and blood tests, but figuring out what that is. The problem is patients with eczema have really high IgEs. So the IgEs could be hundreds or thousands, even tens of thousands. And if you do a blood test on that patient, everything is positive, right? It's just garbage at that point because they're not
Because the test, a positive test for food generally has about a 25% predictive value. So so you come in and you get 3 tests that are positive. For each of those positive, there's 75% of the time you feed the food, nothing happens.
I see.
It's just the nature of the testing. It's just not very specific. So you need the clinical context.
So you don't recommend then food restrictions in treating eczema? Is that what you're saying?
So in rare patients. So there's a subset of patients. So typically for the mild to moderate, there is in the mild to moderate, maybe there's 1 to 5% that where food will trigger their eczema.
Yeah.
In the moderate severe, now you're getting to 10 to 20%. So the answer is yes, in a select population.
Yeah, but the whole concept of I have a 2-year-old with eczema, I better do big food panels to figure out what the cause of the eczema is. It's a pretty failed strategy. We've moved beyond that. We do that. And elimination doesn't really help other than egg and egg allergic atopics.
You gentlemen know that the patients come in, usually they're sophisticated. They've already gone and done internet websites, searches, and they come in with a list of things that they need to do.
What we do is we don't just tell them what we think, right? We have to explore the question. So when I very regularly, every clinic or every other clinic, I'll have a new eczema patient and there's some allergies that are listed on my information intake form. And let's say I have a trainee with me who comes out of the room and I'll say, oh, I see nut and cow's milk listed. I said, what's that mean? Do they have problems with that? And they look at me like, what do you mean? I said, well, are they listed because they're positive tests? Are they listed because they had a reaction to it? Okay, and then we walk in the room and it's listed and that's the variability. They'll say, no, actually, those came on tests and my child eats, drinks cow's milk all the time and doesn't have a problem. So it's not a clinical allergy, but they still label it as a test. On the other hand, you have people go, yeah, he had egg and he had hives and now I have an EpiPen. It's like, okay.
Right, so that's the answer. So it depends.
Okay.
So
let's talk one final part about management. We've gone a lot about different things. Oh, by the way, before I get to that question, parents also come in saying, geez, you prescribed this non-steroid for me. I read about it causing skin cancer or lymphomas, that sort of stuff. How do you address that?
Okay, so that's particularly with the calcineurin inhibitors, and they were the breakthrough therapy at the turn of the century. And they were really exciting because they were anti-inflammatory, effectively, can help control a lot of eczema without having the steroid side effects of problems with cortisol. The history of the development of them is that, in very potent form used orally or IV, they suppress the immune system very aggressively. So they're used as drugs to prevent transplant rejection. Used topically, there's very little absorption, and so the FDA was concerned partially because there was about a 60% drop in topical corticosteroid use and a lot of use of these drugs very quickly, and there was a lot of use under age 2 where they hadn't been approved and studied. FDA can't just put prescriptions on advertising unless there's safety warnings. And so they put together the panel and they came up with really a theoretic risk of cancer based upon animal studies where they're given at systemic high levels. So the data so far, most of the data sets have been very negative for any risk of either skin cancer or lymphoma. There's some controversial studies now and then that say there's still a little relative risk, but they're very tricky epidemiologically because patients with atopic dermatitis on its own have a higher risk of lymphoma than patients who don't have atopic dermatitis. So you get into very different complicated epidemiologic determinations. But the punchline, what I say to my patients is, look, If you can get managed with just moisturizers or with topical corticosteroids a few times a week,
Fine.
fine. But if you need something more to manage your disease, then we can either use these products or a topical PD4.
Okay. One last thing in management, then we'll have to go on, and that's comorbidities. Because you talked about allergies, food allergies, etc. Tell us about comorbidities with eczema dermatitis.
I'm sure Jeannie sounds like she's had several of them. So I mean, so as Larry was saying, so when the more severe you are, the more likely you're going to have comorbidities. So you have two broad topics of comorbidities. The first one is the atopic one. So about a third of of the severe patients will have regular food allergies, and it goes down as you get less. A lot of patients will have asthma, have allergic rhinitis. They can get contact dermatitis. And then too, when your eczema is poorly controlled, you're having poor sleep, so they get depression, they get anxiety disorders.
ADHD
really
increased. The first study came out, maybe the eczema people are fidgety, they're interpreting it as ADHD, but then there have been several other studies as well. So it may be a consequence of long-term sleep disturbance, people don't know.
Yeah, it's no sleep, you just don't sleep.
Yeah, so
insomnia, atopic dermatitis, asthma, possible ADHD, any others?
Anxiety and depression.
Anxiety and depression.
Mood
You
disorders.
have severe disease.
So severe disease, depression is actually really, really common.
So if you treat the eczema or the eczematorial dermatitis, does that make the comorbidities improve?
Well, anxiety and depression, yeah, definitely. They've done clinical studies with the new Biologic agent and with the Dupilumab studies. Like really, they have these objective depression scores. It's like they really, on Dupilumab.
Yeah, well, I actually had to go on short-term disability from work. I was completely, I had the worst, and had tried every sort of, I was on cyclosporin for a couple of years. I really did everything. And then I went into a clinical trial for Dupilumab, and that changed my life because I did not get the placebo. I got the drug, and I all of a sudden did not itch anymore, and I could sleep. And even though it took a while for the eczema itself to go away, that changed my life completely. I was able to I have a daughter. I was able to play more with my daughter, pick her up, able to sleep and. Just completely life-changing.
And as a result of being on that medication, have you had to lessen the topicals?
I don't use anything else except for moisturizer.
Wow, very impressive.
Well,
that goes right into our next section, which includes emerging and future therapies for managing atopic dermatitis. So let's get right into that. So she talked about one medication approved. Is that the main medication recently approved?
I said before that historically we didn't have great systemic medicines and none approved. So she was on cyclosporin. Cyclosporin can control some eczema, but it's a nasty drug with lots of side effects and concern about malignancy. And that the principle of therapies like that in prednisone is to cool out the whole immune system because that's the way these drugs work. They're highly immunosuppressive. And then in the new age, we have much more selective impact on the immune system. I tell people if it's like I want to turn off the electricity in a kitchen in an apartment house, it used to be you would turn off the electric main for the block. That's cyclosporin. I mean, you're shutting off a lot more than what you need to impact the eczema. But with biologic therapies, and then also there are going to be some oral selective therapies called small molecules, we can much more selectively decrease the inflammatory pathways that are important in eczema. So Dupilumab, which she is on, is an IL-4/13 blocker. And how do we know IL-4 and IL-13 is important in an atopic dermatitis? The punchline is that if you block it and you have stories like that, you know it works. And so there's this, over the next decade, 15 years, there's going to be this continued set of medicines that are targeted to little parts of the immune system that we think are important in atopic dermatitis, and we'll find out how potent they are. And there'll be some patients who get totally clear and need nothing other than moisturizers afterwards. There are going to be some people who may get 50% better. There are going to be some people who that's not the drug for them because they don't get better enough. But then there's another drug behind that may be an IL-13 blocker, or there are these agents that are called JAK inhibitors, which is a different inflammatory pathway, that oral medications. And then there's also new topical medicines as well, which may be more practical in the hands of primary care. Well, the takeaway is going to be that part of the burden in primary care and the burden for patients and families is to keep up with these incredible breakthroughs and figure out what's the right for primary care practice once you get someone.
But this is an injectable medicine that you're talking about, right?
Right. So
how do you convince a patient, or how do you pick the right patient to be on injectable medicine?
So
I'd ask her first.
Anything's better than what you feel like.
You
when
were
you have
disabled
severe,
with it.
Yeah, I was
Yeah.
disabled with it, yeah.
Yeah.
So anything is better. You don't think about the needle at that point.
So recognizing the translation of primary care practitioner is to say, and people I think get scared, the doctors, that, oh my God, I don't really have an hour to discuss stuff. But sometimes it's just like saying, okay, you're doing this, this, and this, and this.
and you're failing.
And it's
How are you?
failing.
Yeah.
Nothing's working.
The answer is that simple. Look, you've tried A, B, and C. You're failing. You're miserable. Let's try D, E, and F.
In share patient decision making, you should say, you shouldn't tell them that they're miserable and failing. You should
No,
say, do you think that you're failing and miserable?
What I want to know right now is, how do you pick the right patient to go from the typical, traditional topicals,
So it's-
bathing, skincare,
Yeah,
and
but-
then you say, look, this is the time.
So it's relatively simple. Look, you look at, this is what we were talking about before. You look at the patient and say, look, they have active disease, and you're trying, you moisturize your topical steroids, your topical non-inflammatories. Disease is still active. Whether it's every day or just lots of flares, we got to do something else. And it's really that simple. You can, and it is, you look at the patient and say, hey, and the patient will say, I'm tired of this. I want something else too. So it is that.
I have a medical punch list for when I'm going to consider systemic therapy.
Okay.
And it's number one, make sure it's the right diagnosis and not something.
Of course.
else. And that's usually pretty easy. But I will always consider allergic contact dermatitis, whether I need to do testing. If they come in with regional disease, face and chest is involved. Those are the kind of patients like, can you go to Bath and Body Works?
Oh, no.
No, see, that's like
I
a
can't go
question.
down the
That's
laundry
like a-
aisle
that's
in
like
the
a good
grocery store.
clinical question. Okay, if someone's so rigorous allergic, they sort of know. She knew where I was going when as soon as I said Bath. Like, I can't go there. They're so so that's exacerbated. So one is to diagnosis and consider allergic contact dermatitis, not necessarily testing, but at least consider that.
Okay.
Number two, it's going to be, do they understand their disease and have they had an appropriate trial of appropriate topical therapy or topical plus adjuvant therapy? Not just that they didn't use it because they haven't used it in 8 years because they didn't believe it worked. That's number two. And number third is going to be, is it impacting their disease significantly? And that's where it's their life significantly. And that's really, it's assessing psychosocial impact, but it's really like, how are you doing with your disease?
Yeah.
And because that gets them, number one, to understand that you can get that it might not be great for them, that their disease is so affecting their life. And then that's the partnership. We'll talk about
Yes.
we moved into the partnership, but that's part of my punch list of medically what you need to do to consider systemic therapy.
What about somebody with moderate or even mild disease?
For the mild disease, the answer is no, with an exception, right? So the exception is if you have lots of those comorbidities, say, whether for the atopic one, say, hey, I have asthma, allergic rhinitis, and all these other things. Some of these systemic are going to treat everything. So you maybe say, look, hey, I'm going to give you one agent. It's going to take your asthma under control, your eczema under control, your allergic rhinitis. So you make it one agent to treat everything.
Did you get better with other comorbidities?
Yeah, some of my allergies are much, much less now.
Wow.
Yeah, just
Well,
like seasonal allergies.
Okay, so it's,
Yeah.
with everything that's really great, there's always, of course, a downside. So what are the downsides, or what precautions, and what are contraindications?
So, I mean, we're a few years into very robust studies, but that's not 10, 15 years. And so one of the questions that came out is, okay, this is selective immunosuppression, but what's important about the light in the kitchen, or as an analogy, or what's the downside? So with dupilumab, for instance, the infection data looks pretty good. You have less infections if you're on dupilumab than if you're not on dupilumab. Okay. But conjunctivitis is something that's seen in a small subset of individuals associated with dupilumab.
Okay.
It's peculiar. We're still trying to figure out what it's from. Usually it can be treated and people can stay on the drug, but other people just have to come off. Now, as we have different kinds of medicines that come through, there's going to be stuff that's predicted in terms of potential side effects and others that aren't. These are immunosuppressive agents, but they're very selectively immunosuppressive.
Yeah.
We'll always be looking at, increased cancer risks over time, but there's no evidence of signals like that.
Okay.
Generally, the safety has been incredibly exciting. Shots, are, again, most don't care if it's really going to fix them. Cost is definitely an issue.
That's the big one.
These
Yeah.
are very expensive
Yes,
medicines,
very, very,
and
yes.
access to the medicine is definitely an issue for
How often are
patients.
these administered?
Every 2 weeks.
Every 2 weeks?
Every 2 weeks.
For this
Any
one,
side
and
effects
others
from it
like-
that you've had, Janine?
No side effects.
No
I
side
didn't
effects?
get the conjunctivitis. I do know, like, I'm part of some online groups that are part of the clinical trial and whatever, and there were people that had it pretty bad, but I didn't. I was
Can it
From
be
a
used in-
primary care perspective, just
Yes.
to let you know, so that the set of blood work that you need to get
Yes.
before you start this particular biologic, and then every few months, none.
None. There's no
So
blood work.
there's no-
So
there's
no
no
blood.
need for
which
any
is
blood work.
amazing. I
Right, so
had
like
blood
with-
work every week with cyclosporin.
Like cyclosporin, you have to get a blood level all the time. So this one, the one very theoretical downside, so this is purely like in mouse models, right? So this is one is learning. So theoretically, IL-4 and IL-13 may play a role in learning. So that's the one theoretical thing, but it's truly in mice. So no one's seen it in humans, but
I'd say
Okay.
generalizes
Well, we don't
that-
treat mice, so
that's
we're
right.
okay.
it doesn't seem to be infectious, doesn't seem to be cancer, anything like that,
Yeah.
or liver, or kidney, all those things
Okay,
to be
can
completely
we
fine.
use it in teenagers as well as children?
So
or-
it's only approved right now 18 and above. The clinical trials are ongoing right now from 12 to 18. They're starting the 6 to 12 in the next several months, and they're eventually going to work all the way down to 6 months of age.
How do you convince an adult to be on a shot every 2 weeks? Isn't it difficult?
No.
All right. So we're talking about new advanced treatments, which is really interesting. I mean, in my experience in primary care, it was basically what we've already talked about, topicals, but you've given us some great advice on some specifics on topicals as well as good skin care. Anything more on the horizon coming up? You said a few things, but can you give us some more details on that?
Yeah, so there's going to be different biologic agents that are patterning different parts of the inflammatory milieu, and some are in phase 2, so they're a few years away, not quite in hand, but they're there, and I think that it's going to be important because not everyone has the profound response that she has, and also, so far we haven't seen loss of efficacy over time with the systemics, but that's always a concern. So there's going to be new biologic agents that just pattern different subsets of the inflammation. There's oral medications, oral JAK inhibitors in particular, as well as topical JAK inhibitors. And JAK inhibitors are just a different pathway. They're going to be sort of like, the topicals, I think, are going to be like topical steroids, but a little more selective, without the side effects of thinning. They don't have cortisol, so they're really exciting as well. And then there's a set of agents that are trying to target itch, either the immunology of itch. There's an IL-31 is the itch cytokine, and you can block that. And that's approved for atopic dermatitis in dogs already.
Oh, wow.
An anti-IL-31
Interesting.
antibody.
It's going to be a whole new series of things to find out. And the interesting thing is, we don't know who's going to be the IL-31 person, who's going to be the IL-4/13, who's going to be the JAK.
Yeah.
We don't know. People may respond to everything. People may respond to just one. We don't know yet.
Stay tuned?
Stay tuned,
Okay.
I would say.
So, gentlemen, you talked about injectable medication. Any new topical medications on the horizon?
That's another example of how insights into eczema can translate into therapy. So years ago it was figured out that in circulating inflammatory cells, there was this enzyme called PDE4, and the PDE4 was very active in eczema cells, and it basically, through the cyclic AMP pathway, would be consumed more rapidly, and that was associated with release of inflammatory cytokines. And then people said, can we block PDE4, keep that cyclic AMP not consumed, and block the cytokines? So now we have an approved topical PDE4. Crisaborole is the generic name, and it was great. We had gone through a time period without a new topical drug being approved since 2001. And this is not just a new topical, it's a first in class.
Yeah.
So it's not a steroid.
Yeah. It's not a steroid, it's not a calcineurin.
Not a calcineurin
inhibitor.
The safety data seems incredibly good. There was so basically it was a big robust study with lots of kids in it as well. It went through a month treatment, and then there was a 1-year continuation study where people either used it continuously or cycled on and off on the different months. And the long-term safety study found essentially nothing that popped out different than the 1-month study. There can be some stinging and burning in a subset of individuals that usually goes away with a day or two of application. And other than that, there is really no real negative that's emerged in the safety standpoint. So that's an exciting medicine to have, because if you need something other than topical steroids, it's another alternative besides the calcineurin inhibitors. There's no evidence of any malignancy signals.
So
you don't have to even
it's out on the
do that.
market. It's prescribable. Is that correct?
Absolutely.
Yeah, right.
Yeah.
So and
it's a topical.
It's a topical. I think about using it in two ways. One is that we can use it for flares, right? Like we do topical steroids. But the other one, this is potentially, as Larry was talking before about the proactive therapy. This may be a potentially really good compound for the proactive therapy. Using it almost as maintenance, because it seems to be so safe and doesn't have some of the steroid skin thinning that we theoretically worry about. So it seems to be a very great in a molecule for that.
In the 1-year study, there were patients used it for 6 months to a year, and some off and on, and some continuously, and you could definitely get that sense that the time for them till they needed something else, for some rescue medicine was really low.
So it's a medication that you use on top of steroids or in place of steroids?
Or it can be used in place
both.
of steroids, or it can be used in regimens of care in
So
combination.
the answer is either or.
Okay.
Yeah.
Did you try it?
I have not tried it because I've been on the systemic stuff, but
Okay.
I would have. I tried in the 2000s when, what did you guys call them? The calcium.
Calcineurin
Calcineurin
inhibitors.
I those were very exciting to me at the time,
Yeah.
and I used all of those. And,
Okay.
Yeah.
Excellent. You know what? We've been talking in all these 3 sections about discussing their condition and their care with the patients. And in medicine we now call this shared decision making, which is like an intuitive thing. Shared decision making. You share your decision with your patient. But specifically, why is therapeutic education in shared decision making so important?
And so when you think about it, so it's just as you said, it's sort of like the obvious, like, oh, come on, you got to
Talk to your patient.
The patients are going to be doing it. So it is a team effort, and you really have to say, look, here, this is in our therapeutic options, is having that conversation, knowing what's important, and then you can, because as a physician, we have lots of good medicines. We need patients to take them. And this open sharing decision making really helps.
And that's one of the things. This is really something that's evidence-based that's coming into medicine. That with chronic diseases, we will have better outcomes, patient outcomes, whoever's looking at them, if we take our time to make sure, not that the patient's on our page as a doctor, but that we're on the same page.
Yeah.
And it's a methodology that we bring to it, and it's hard. I mean, to be truthful, it's hard to make a move to that psychology because people are pretty busy, and it's much easier to walk in the room and go, yeah, eczema's pretty flared, why don't we use this and give them a prescription. That's the methodology. I'll tell you what I think you should do. Or if I walk in and go, you need to use crisaborole or dupilumab or whatever, and the results aren't as good as if we work together, but essentially seek the patient's participation in the process, explore what the treatment options are, and then get a sense of where the patient's at, and then move into making the decision. And then evaluating how it works.
Yeah.
In primary care especially, we're oftentimes pressed for time, and you know what it does? Intuitively, we default into, let's just tell them what to do, and they can, they can do what they do. If they come back, they're not doing well, I'll tell them what they should do again.
Right.
But what you guys are suggesting, though, is have them get involved.
Telling them what to do will take you 30 seconds, but if you take the extra 3-4 minutes, it's not an hour. Hopefully it's not some patients it's an hour conversation, but most of the time it's maybe an extra 3 to 4 minutes. You're going to save it on it. They're not going to come back every 2 weeks like, it's not working. They're calling in, what you gave me isn't working, right? You'll save time and there's actually studies that actually prove this. If you make that effort and get the patient involved, it's going to take you less time total than them not doing this sort of doctor-driven.
We think we're doing okay? You think we need to do better with that? How are your experiences?
I've actually found that in like dermatology and allergists and primary care, I've had people who have taken that extra time with me. It's been overall a positive experience, actually.
Excellent. Yeah, with shared decision, Janine, we're talking about a clinician. First of all, informing a patient in an understandable way what their condition is with repetition, and which means having them come in several times to discuss what's going on. But then also having the patient express their concerns, their apprehensions, their excitement about what you've told them and perhaps what you've asked them to read. Do you, by the way, give information in reading form or websites for your patients?
Yeah, so there's a whole therapeutic patient education movement in atopic dermatitis. The Europeans actually were really ahead of us in that. And the whole tools of what to be able to supply are building now. Most of us usually use written care plans. There's video materials. There's websites like the National Eczema Association website that have nice materials. So I think it varies. And that's something where that's a gap. There's a practice gap between primary care and specialists that we hope to fill, where I hope we can supply more materials to primary care and
so that's one of the things
that's easier for you to do it too.
Okay.
That's one of the things that Cube C is trying to work on, is that educational piece.
Okay.
You can get it through National Eczema Association, through the other professional allergies associations, whether the Allergy Society, the Dermatology Society, all have it, but the NEA is really working on that to develop that great education that here's a website, or here's a video, or here's that piece of paper that you can hand out.
So if I have a patient coming in and I really want to educate them on it, and I give them information, as we all know, maybe only 10% stays, but I try to reinforce by having them come back. If I ask them to go to the Cube C website or the National Eczema Association, they'll have information there that they can read?
The
Yes,
National Eczema Association
will
has-
have has all those things.
The good news is that there's more information,
Yes.
and we want to drive better outcomes, so getting the patients more educated in that
And
process.
it's also
is
good to
gonna-
have it like, the education that you're giving out to people is not just like Dr. Google or whatever. It's very specific and scientifically backed.
Yeah,
Yeah.
I really
Janine,
believe that.
You said that a lot of your clinicians were involved or had you get involved in
Yeah.
the decision making, so obviously there were some positives. Any advice that you can give clinicians listening in right now on what they can do?
What they can do? Well, I think that just like, I think that listening to what the patients have tried and just a little bit of, how it's affecting their life and seeing where you can try to help with that. And, it's been helpful for me to go back and forth with the doctor because they kind of understand. They're the only other person who sees someone like me, that I don't see someone like me that often. But, so it's nice. It's like almost like a colleague discussion at that point. You both get it.
And was there anything that specifically stands out in your memory and in your thinking of what a clinician did that was really good, and you wish that it would be replicated with other clinicians?
Just giving me my options very clearly of like, here are 3 different options, and like, when I went on cyclosporin, it was like, okay, this is a really tough drug. Like you failed all these other things, but here, this is an option for you, but you're going to have to do this, this, and this, and there's a risk of lymphoma. So it was a hard decision, but it presented the options, gave me the decision to make, and I eventually decided to go with that.
Again, I think that what we're really trying to say here, with chronic conditions, and you said it very well, Larry, with chronic conditions, you got to spend time with your patients. This isn't strep throat where you say, take this antibiotic, I'll see you later. It's one where you're going to be seeing your patients regularly and often. There's going to be waxing and waning periods. There's going to be information you have to share with them, places where they have to read about the condition that they have, give them ample opportunity to express their opinions, spend some time with them. Isn't that right?
Yeah.
Yes.
Well, gentlemen, this has been excellent. We have talked so much about this very important topic, about diagnosis, about management, about specialists, about new things. Speaking of new things, let's say you had a crystal ball, which you do in your office, right? And you're looking at your crystal ball. What about therapeutic management shows up in your crystal ball?
I think when we think about therapeutic management, it's obviously all the new biologics coming out, and that's probably the most big thing. If I had my crystal ball, we'd be able to do the big thing nowadays in medicine is the personalized medicine. We'll be able to say, hey, you are a great candidate for the IL-4/13 inhibitor, and that's going to be your thing. Like, no, this is not the one. You're going to need IL-79. I don't know if there's an IL-79, but
Sounds good.
But there'll be something like that you'll be able to look at that, and that's probably where medicine's going to head in the next several years, is that idea of personalized care.
Okay.
I'd say that I believe that our primary care docs are going to do better with mild and part of moderate disease because they're going to learn more about eczema because of the new topicals as well as the new systemics, and because of the information that's coming forward. They're going to recognize that, and they're going to do better. And will also recognize earlier the moderate severe patients who can benefit from more aggressive therapy. And what we're really hoping is that figure out in where the right intervention point is in kids, so we can turn off the disease process and turn off the development of the secondary issues that are associated with it. And I think we might be able to do that, and that's really exciting.
Excellent. Janine, from your crystal ball as a patient, anything you want to say?
Oh, the same. I mean, everybody wants a cure, but I think that, having personalized medicine is the next best thing, basically.
Well, this has been a very exciting topic to talk about, especially with so much of the valuable presentation that we've had. Thank you, Jonathan. Thank you, Larry. And thank you very much, Janine, for being here.